Thank you very much, Rupert and Sarah, again for organising this meeting. I think it was a real shame last year that it couldn't take place, and the fact that you've persevered is just an amazing feat. Next slide, please. I do have a disclosure. I'm working with a pharmaceutical company in New Zealand to develop a controlled release oral ketamine tablet, and I'm named on a number of patents for that. Next slide, please. This is a little bit of a sort of a historical deep dive that it's reporting studies that were originally planned in 2015. And at the time, there were very consistent positive findings that ketamine was working in treatment-resistant depression and bipolar depression from a number of international sites. And there were two additional positive findings in anxiety-related disorders. So Feder's report in PTSD and Carolyn Rodriguez's report in OCD. And our thought was, well, could this be a much broader effect? And we wanted to look at ketamine's effect in generalized anxiety and social anxiety. And there was a rationale in the sense that the brain network activity in depression and anxiety seems to show a lot of similarities, and that there were similar alterations in glutamate signaling. Next slide, please. And the initial plan was to do a three-stage study. We wanted to recruit patients who had treatment-resistant generalized anxiety and or social anxiety, but no current major depression. And again, the thinking behind that was, if people were significantly depressed, the improvement in anxiety symptoms could be an epiphenomenon of the improvement in depression. So that was why we excluded major depression. And in terms of severity, patients had to have a Hamilton anxiety score of 20 or more, or a Leibowitz social anxiety score of 60 or more. And these are well-established cutoffs for at least moderately severe anxiety, generalized with the HAM-A, or social anxiety with the Leibowitz scale. And the initial study was simply to do an open label dose response in 12 patients. And at the end of that study, we had a data safety monitoring board to adjudicate, are you seeing a positive treatment effect? And if we weren't, we would stop at that stage. However, we did see a positive signal. So we then had a second study, which used the same dose response, but had midazolam inserted randomly in the sequence. So the doses of ketamine that we chose were 0.25, 0.5, and 1 milligram per kilogram given subcutaneously. This was weekly dosing, and the reason we chose the doses that we chose were that in some earlier work that we carried out with Colleen Liu in patients with major depression, 0.25 of ketamine seems to be right at the threshold of response. 0.5 and 1 seem to be reasonably active. And we used a low dose of midazolam as the psychoactive control. And for patients who showed an improvement on either the Hamilton Anxiety Scale or the Fear Questionnaire during the ascending dose phase, were eligible to go into a maintenance phase where we would continue with either once or twice weekly dosing. We found that about half of the patients needed twice weekly dosing, that the effects wore off relatively quickly, and all patients eventually wound up on 1 milligram per kilogram. And the longest we could dose for was for 3 months. So that those are really our data. Next slide, please. And the assessments that we carried out were vital signs over the first 2 hours. So patients would be sitting in a big comfortable chair for 2 hours after dosing. We looked at dissociation using the CAD scale up to 60 minutes. And we used the fear questionnaire and Hamilton anxiety scale from pre-dose up to the end of the week post-dose. The fear questionnaire was designed by Isaac Marks about 50 years ago, I guess, and it looks at a number of phobic situations. So personally, I think it's much easier to use than the Leibowitz scale for patients with social anxiety symptoms. And during the maintenance study, again, we monitored vital signs out to 2 hours, looked at dissociation, only looked at phobic symptoms and anxiety ratings to 2 hours. And we also looked at I guess, a functionality scale using the work and social adjustment scale. Next slide, please. And in terms of patient disposition, we had patients with predominantly comorbid social anxiety and generalized anxiety in both studies. If one looks at the baseline rating scales, the Hamilton anxiety was 26 to 28 in both of the ascending dose studies. The Leibowitz social anxiety scale was in the high 80s or low 90s, which again is suggestive of extremely high social anxiety, and MADRS scores were quite low. Of the 24 people who completed the ascending dose studies, we enrolled 20 into the maintenance study, of whom 18 completed. Next slide, please. This is the initial 12 patients that we put through, and I'd like to concentrate on the left-hand graph for a moment. This is the phobic anxiety questionnaire, and it's looking at the change in fear questionnaire ratings over the 168 hours. And one can see that there's an immediate reduction within 1 to 2 hours in fear questionnaire ratings. And there's a dose response. So the effect of the 1/4 milligram per kilogram is quite fleeting. There's a bigger drop after 0.5 milligrams per kilogram, that's the red line. And the black line, which is the 1 milligram per kilogram, shows the biggest reduction in ratings, and there's a greater durability of response. Middle graph, we're seeing a roughly similar pattern with the Hamilton anxiety score. And on the right-hand graph, this is looking at ratings of dissociation. And as we push the dose up, we see greater dissociation ratings that peak at about 30 minutes and are either gone or starting to descend by 60 minutes. Next slide, please. And for the double-blind dose response study, we add in one additional line, which is the midazolam line, which is the green line. And we're seeing, again, very similar trends there, that as we push the dose up, we see a bigger drop initially, that we're seeing an improvement within 1 hour for both the fear questionnaire and Hamilton anxiety scales. The midazolam seems to actually have quite a substantial effect on the Hamilton anxiety ratings. That's the middle graph, but relatively small effects on phobic symptoms in the left-hand graph. And again, these are not surprising findings. And midazolam has no effect on dissociation whereas the 3 ketamine doses do in the right-hand graph. Next slide, please. We also measured pharmacokinetics in the double-blind cohort of the study, and one can see that both ketamine, which is the left-hand graph, and norketamine concentrations show a dose-related increase. Ketamine levels peak at around 15 minutes and then decline rapidly. Norketamine levels rise more slowly, and again, that's not surprising given the way that ketamine is metabolized. We always see slightly higher concentrations of the R enantiomer compared with the S enantiomer, and again, this has been reported in the literature, and there are some metabolic reasons why this might occur. When we correlated clinical symptoms or clinical responses with the pharmacokinetic data, we see the only correlation was with peak ketamine concentrations and CAD scores, and we reported this in the study that we published with Colleen Liu back in 2016. We also looked at serum and plasma BDNF concentrations, and our hope was that changes in this would provide some peripheral biomarker of what we think might be an important transcriptional change in brain. And it's been very disappointing. With this and with some of the tablet studies we've completed, we've collected a lot of BDNF data, and it really is completely uninformative. So, so long for this being a potential biomarker. Next slide, please. We also looked at dose response. So we took all 24 people who'd completed the ascending dose part of the study and looked at percent change from baseline in 3 different rating scales at 24 hours post-dose. So the fear questionnaire, the red line and red symbols, Hamilton, the black line and black symbols, and we also looked at the Spielberger State Anxiety Scale, and we see that they all show a dose-related greater reduction in scores. These appear to asymptote after 0.5 milligrams per kilogram, and my feeling is that in the same observations from Maurizio Fava, who published on this in patients with treatment-resistant depression, they certainly showed that 0.5 and 1 milligram per kilogram gave a greater improvement in depression ratings compared with lower doses. And we seem to be seeing the same thing here for generalized anxiety and social anxiety. However, it is interesting that on an individual patient basis, that when people went into maintenance, that they all wound up on 1 milligram per kilogram. So I think the idea of dosing at a population level versus an individual level is still a bit of in my mind, an unresolved question. Next slide, please. These are maintenance data. The left-hand graph is looking at fear questionnaire ratings. Right-hand side is Hamilton anxiety ratings. On the vertical axis, there's a gray blob that gives the mean score rating prior to initially getting dosed. And for the fear questionnaire, the red line is the patient's score but before getting dosed, and then the black symbols below that are the scores at 1 hour post-dose. The for the fear questionnaire, it appears as though it takes eight weeks or so before we get asymptote. Whereas in the Hamilton Anxiety Scale, by 2 weeks, patients pre-dose have basically achieved the lowest score that they're going to get. And it's quite possible that for the fear questionnaire, because it has a phobic avoidance element to it, that some measure of exposure is needed. Whereas for the Hamilton Anxiety Score, it's simply looking at a range of psychological and physical symptoms of anxiety. So that there may be no exposure needed for getting maximal benefit. In functional terms, patients did incredibly well. They got jobs. If they were working, their performance at work improved. They were able to go out on dates. They were able to go unaccompanied to supermarkets. It was quite an extraordinary improvement. And at the end of the study, 25% of patients remained well. We stopped their ketamine, and there was no recurrence of anxiety symptoms. And for those of you who deal with patients with anxiety, these tend to be chronic disorders. So the fact that a quarter of patients did not get recurrence of symptoms, to me, is quite extraordinary. 50% of patients had anxiety come back, but to a much less intense degree. And a quarter of patients got their anxiety symptoms back within a couple of weeks of stopping dosing. Next slide, please. Other observations, and again, this is not part of a randomized trial. We had 5 patients who had comorbid panic disorder, and during both acute and maintenance treatment, their panic symptoms just disappeared. And then finally, a lot of patients had specific phobias, especially blood injury phobia. And one of the subscales of the fear questionnaire looks at ratings of blood injury phobia, and the ratings on the scale decreased. And we've recently finished a study in patients with spider phobia, looking at oral ketamine, and we see a quite remarkable reduction in phobic anxiety when they're exposed to virtual reality spiders. So it may well be that there's a very broad impact of ketamine on anxiety disorders. Next slide, please. So since we started planning and carrying out the study, Jerome Taylor has published his crossover study in social anxiety that showed a positive effect. There's a very nice narrative review by Banov and colleagues looking at ketamine on anxiety disorders and anxiety symptoms in patients with depression. And then we just heard from Dr. Fader, who's I think published some beautiful repeat dose ketamine data in patients with PTSD. Next slide, please. And so just to wrap up, I think we've shown in 2 studies that 0.5 to 1 milligram per kilogram of ketamine has quite consistent rapid onset anxiolytic effects in patients with treatment-resistant generalized anxiety and social anxiety, that we can maintain these effects with maintenance dosing, and again, on an individual basis. Some patients can survive on one dose a week. For others, we need twice weekly dosing. And I think one of the most intriguing findings is that ketamine could have a broad therapeutic role across all anxiety disorders. And for a condition where there's an enormous amount of treatment resistance, this could really revolutionize management of patients. I'd like to acknowledge funding from Health Research Council and James Hume, and I've listed a number of very important collaborators as well. Thank you very much.